All right, everyone, it's 4 o'clock. Welcome to another edition of Tumor Talk. This is the collaborative effort between Lenox Hill Neurosurgery, the Journal of Neuro-Oncology, and the Joint Tumor section, where we highlight recent publications in the Journal of Neuro-Oncology, and we invite the authors. Welcome, Dr. Weller. And they discuss their kind of rationale for the study, their results, and really the clinical relevance to how we practice, surgical neuro-oncology. So, Dr. Weller, I want to thank you for being here. If you'd like to take a minute, introduce yourself, and we can dive right in. We like to keep things short and sweet, so about 30 minutes or so. So welcome.
Thank you very much, Dr. D'Amico. Thank you very much for the invitation as well. So my name is Jonathan Bella. I'm a resident in neurosurgery at the University Hospital of Munich. And thank you, Dr. Sheehan and Dr. D'Amico. It's an honor for me. I'd like to talk about temozolomide chemotherapy for astrocytomas. That's what we published in JNO a couple of months ago. And I'd like to say a few words about the background of the study and the rationale. So the general treatment guideline for a newly diagnosed astrocytoma, as you know, is the maximum safe resection. And this is followed by radiochemotherapy if deemed necessary. This, in general, depends on various risk factors that are to some degree controversial. I cited the Buckner trial published in 2016. There, they say that the main risk factors is obviously postoperative residual tumor volume and higher age. I think I've heard that some people don't believe in the higher age. I'd very much like to hear your opinion on that later on, maybe. And then another controversial risk factor might be the WHO grade, at least if you talk about grade 2 and 3. Grade 4 seems to be a little more aggressive. So this is the general recommendation. And I also cited two papers published by Martin van den Bent. This is the CATNON trial, the very important CATNON trial that actually showed us that the addition of temozolomide to radiotherapy is beneficial in anaplastic astrocytomas. So what do we do with a young patient who has a huge lesion, maybe left hemisphere, and maybe not the perfect case for a tumor resection? And maybe we don't want to irradiate him because the volume is huge and we fear neurocognitive decline as a side effect from radiotherapy. There, the guidelines to some degree give leeway for monochemotherapy, and this mainly comprises PCV, although this is mostly done for oligodendroglioma, of course, and then temozolomide monotherapy, although data are scarce on these therapy regimens in these tumors. So in young patients and in patients with huge volumes, there is the possibility to defer radiotherapy and just go for chemotherapy in the beginning. And so this is the background for therapy. And then in the last couple of years, there have been some reports talking about temozolomide and potential even negative effects on IDH mutant gliomas. And I have listed a few of them here. You see two Nature papers that described a hypermutation phenotype potentially induced by temozolomide. And then from last year, there's a paper published by UCSF group, and they reported that this hypermutation induced by temozolomide is also associated with aggressive recurrence and worse prognosis in general. This doesn't seem to happen in every IDH mutant tumor, but in some. And this is probably due to a acquired mismatch repair deficiency after temozolomide therapy. And within this framework of studies, we have conducted a study here at our center, and I want to show you the concert figure very quickly. There you see that we included patients between the years 2001 and 2019, and we looked for astrocytomas WHO grade 2 or 3, and then we excluded cohorts where we just had a few patients and those with missing data, and we were left with 183 astrocytomas, and they could be allocated to 3 different treatment groups. That's what you see on the right. Those are not all important patient characteristics, but some. I just wanted to give a quick overview and talk about other characteristics later. And what you see is that we had 98 patients that were not treated after biopsy or tumor resection at all until first progression. Then we have some patients, 48 patients that received temozolomide monotherapy after biopsy or tumor resection. and then 37 patients that were treated with radiotherapy alone. You see that if you look at the patient characteristics, you see that the patients from the median age in the radiotherapy group was a little higher. You see that the proportion of WHO grade 2 to 3 was identical between the temozolomide cohort and the radiotherapy cohort, but of course, as one would suspect, substantially different in the wait and scan cohort, as there were many patients with WHO grade 2 gliomas. So then I just want to show you the overall curves in the beginning. So of course, this is subjected to a lot of selection bias. I want to talk about that a little later. And what you see is the progression-free survival on the top left and the overall survival on the top right, and then stratified according to these 3 treatment cohorts. And what you see if you just look at the green radiotherapy curve and the blue wait and scan curve, you see that radiotherapy seemed to be associated with a prolonged progression-free survival, but this did not translate into a improvement in overall survival in this overall analysis. This is very similar to a very important study published by Van in 2005. In this study, they looked whether early radiotherapy was better than delayed radiotherapy. This actually provided the rationale for delaying therapy in some patients. And there they saw that the similar effect, basically. And what we also see is that the progression-free survival between temozolomide and wait and scan was virtually identical, but the overall survival was better in the wait and scan cohort. So I wanted to talk about the patient characteristics, and there are very important factors that differ between the groups, and two very, also in univariate analyses, important factors are, of course, the post-surgical T2 volume and the contrast enhancement on initial MRI. So those are risk factors that are known, and what you see is what was to be suspected. The wait and scan cohort had substantially smaller post-operative residual tumors as compared to the other 2 cohorts. You look at the contrast enhancement, you also see that temozolomide and the RT group had a higher proportion of tumors with contrast enhancement. And we tried to take that into account with matched pair analyses, and those graphs I want to show you in a minute. So this graph just focuses on the matched pair analysis and comparison between temozolomide and radiotherapy. We had very limited numbers, as you see here in the curves. And what we saw is that radiotherapy was associated with a longer progression-free survival, but not a significant improvement in overall survival as compared to temozolomide, also similar to another study, to a prospective trial published by Baumat et al. And now, very interesting curves. If you just focus, if you don't talk about the radiotherapy right now, this seems to be the better option in these cohorts. But now we're just looking at the wait and scan cohort and the temozolomide cohort. And on the top, you see 3 graphs showing the progression-free survival, and then on the bottom, you see the overall survival. And top left and bottom left, you see the overall curves. You've seen that in the beginning already. And in the middle, you see what happens if we just look at WHO grade 2 gliomas and then the matched pair that accounted for both T2 volume and additionally both for T2 volume and contrast enhancement. What you see is that the PFS seems to be identical in all of these subgroups, but there seems to be a difference between overall survival, and that the temozolomide cohort has a worse prognosis, not even similar, not better, but even worse. So then we went on and did another analysis, and this might even be the most important graph in the D graph, the one on the top right you see here. So what we did is we just looked at the wait and scan cohort of 98 patients, and we looked at those who had progressed over time. And then we looked at the therapy they received at first recurrence, because then we thought there must be less selection bias because all of those patients were initially not treated at all. And this was the case. Indeed, the tumor volumes were similar. There was no statistically significant difference. And what you see is the same again, that progression-free survival did not differ. But what you see is that that patients that receive temozolomide as opposed to any other therapy at first progression show a much worse prognosis overall. you see that in the wait and scan cohort, initially wait and scan cohort, and then other therapy other than temozolomide, not a single patient died in that whole follow-up time, and those were 42 patients. So summarizing, we are totally aware that this is a retrospective analysis and subjected to selection bias, but we tried our best to account for that. And in general, we think that together with the publications mentioned in the introduction, this data warrants a critical view, at least on a monotherapy with temozolomide in these tumors. It might not be the best idea to just give temozolomide and nothing else in these tumors in the beginning. And we also think that further molecular analysis of these tumors is necessary, that we need to look at the mechanisms of actions underlying these hypermutations. And with this, I'd like to close out, and thank you very much for the attention.
No, thank you, man. Real pleasure having you on board. And I know I speak for Jason when I say that it's we're happy to have you publish in the Journal of Neuro-Oncology for this. I think it's an important study. A few things that kind of stand out in my mind. Obviously, and it's important to clarify because a lot of the viewers are not clinical. You really looked at radiation alone or temozolomide alone. Do you have any insight into patients who get the combination, right? Because for a lot of the reasons that you said kind of in your introductory slide, very young patients, sometimes maybe an eloquent location, residual tumor, we often treat with two. We'll treat with temozolomide and radiation for these types of tumors. So I'm just curious what your thoughts are there, if you have any kind of insight based on the data analyses.
Yeah, so those patients that were treated with radiochemotherapy, either with PCV sequentially or with temozolomide, were not included in this study, but the few patients we had, they have a very good outcome, we have to say. And ever since the CATNON trial was published, we changed, of course, our management as well. I think in general, we traditionally in our department, we have been very careful with treatment, so especially in the earlier years. And now, of course, we benefit from these cohorts because we can look at them, but nowadays we treat them according to CATNON, at least the high-risk patients as well. But I think it's very unfortunate because, for example, the IWAT study that compared the wait or treat study that aimed at comparing radiochemotherapy with not doing anything after gross total resection was closed now. So some of these questions, I think, unfortunately, we won't be able to answer. But as you said, so these patients have a very good outcome treated with radiochemotherapy. Yeah. There might be some complementary effects. I don't know. What do you think about that?
Yeah, that's kind of what I was alluding to. I think it's curious. We have at least a hypothesis for why temozolomide alone may have some deleterious effects, right? This idea of hypermutation and whatnot. And there's clearly some evidence of something going on, whether or not that's the mechanism or not, right? You're seeing that these patients, overall survival-wise, at least, is definitely different. And obviously not the scope of your study, but hopefully future studies can better elaborate on that. But I think it's interesting that if you add radiation to the and combine the treatment, all of a sudden your outcomes are much better. And so that's kind of the route we take here. It's always so nice to see how other places do it and how what is the thought process behind these things. You talked a lot about selection bias, and again, mainly for viewers. In this case, how do you think selection bias really influences your results? Obviously you try to control for it, but there's always a component.
Yeah. So for me, I think the main problem in this cohort is, of course, the tumor volume. We just, we all know these tumors with these gliomatosis like images, and we just don't know what to do with them. And then they have huge tumors. And of course, at some point there was a tumor board back then, and that tumor board left scope for or gave leeway for just doing chemotherapy or for doing chemotherapy. In other patients, they said, okay, let's not do anything. So this is, I think, a very important point that I still think that we tried our best to account for that. And also the radiotherapy group still was better than the other two groups. So even though there were more, the patients were older, and even though there were more patients with WHO grade 2, 3 gliomas, so still think we can talk about these different cohorts, but I think this is the main issue, that if you look at the initial tumor volumes, you have these bigger volumes. I mean, this was associated with outcome, with overall survival in univariate analyses, but the effect wasn't super strong, I have to say. The hazard ratio was pretty low.
And then what about, since the time frame here, you said 2019 to 2021, are you basing the diagnosis on the previous WHO diagnostic criteria, or did you guys reclassify tumors prior to 2020 when they reclassified?
So we reclassified all of them according to 2016, but I think for astrocytomas, IDH mutant astrocytomas, other than the astrocytoma grade 4, I think nothing might have changed. So the grade 4 were excluded. So the astrocytoma setting is
it's pretty much the same. And I mean, just curious, kind of following the same thought process. Did you look at specific, mutations or molecular features of these tumors that might have correlated to a better response to temozolomide or radiation?
So this is an incredibly interesting question. This is what we are doing right now. This is sort of the follow-up project to this project we published in your journal. So we also have a pretty high, unusually high rebiopsy rate. So we approximately 60 to 70% of those patients have received a rebiopsy at some point in time when they progressed. So we have this data, we are working on that, and we plan on analyzing especially tumor mutational burden overall, and then also copy number variants and so on.
That's excellent. Yeah, I'd be looking forward to that, especially the mutation burden, right, with the proposed mechanism and whatnot. So that's great. I'll leave it open for a minute to any attendees if there's any other questions. We like to keep it short and sweet, and you did. And again, it was a real pleasure having you contribute this to the journal. I think it begs a lot of questions, as all good research does, right? It's not providing a ton of answers, but it gives us some insight into a thought process. While people are digesting, I guess one last question would be, and again, kind of how we discuss this always, is, how does this affect your practice now? Let's say a 30-year-old comes in with a right frontal low-grade glioma, you get a gross total resection on it, or what appears to be, are you now changing your mind about how you do, your post-operative adjuvant therapy?
I think to some degree we do. So if we have, let's say, a patient with the right frontal lobe tumor and we have cross total resection, everything is fine. I think we would opt for wait and scan right now. But I just think this is not based on hard data, but I think it might not be a good idea to just give temozolomide to give something. Okay, it's a huge tumor, I don't want to operate on it, so I just want to do something, and maybe temozolomide is not bad, it helps in Cadnon at least, so we give it. But I think there is a very important difference between, if you look at the Cadnon trial, for example, you have grade 3 gliomas, you have patients that were resected and maybe have small post-operative tumor volumes, and maybe, there is data out there that describes chemotherapy as a radiosensitizer. Maybe it's also works vice versa, we don't know. So I think this is very interesting. I think it might be different if you look at the whole tumor burden a patient has, and you just give it everything. You give it the tumor resection, the radiotherapy, and the temozolomide, and it was a more aggressive tumor. Then it's different from a 20-year-old with a huge tumor where you just put temozolomide on a huge tumor and then leave it to its evolution maybe.
Yeah. And have you looked, just kind of running with that for a minute, have you looked at separating the grade 2s and the grade 3s? Because you bring up a great point, which is, here grade 3, we would treat aggressively. It's not even with the gross total resection, the minute you kind of go into grade 3 territory, especially in a young person, we actually argue basically to be more aggressive to get a better outcome. But I'm curious if you have data based on just the isolated therapy, or if you've looked at 2s versus 3s. Might be a power issue, but
yeah, it is. But still, grade was in our cohort, it was associated with outcome. Great, absolutely. So, but that's interesting. What do you think about the risk factors in general? Because I recently talked to Martin van den Bent at a congress, and he said that he doesn't believe, for example, in age as a risk factor in IDH mutant gliomas. What do you think about that?
Yeah, it's a good question. For some reason, I have yet to see an IDH mutant in an older person. They pretty much change over at some point. And so I think that as we get better at defining, gliomas along the spectrum of gliomas, I think we're going to kind of, weed those out a little bit more. I think it's a rare event. And so I agree. I think if you have an IDH mutant glioma properly and you're still older, I think that age is probably less relevant, than it is the actual mutational status of the tumor itself. But for some reason, at least my patients, if the older they get, the more likely they are to be a grade 4 in that situation. Even the non-enhancing ones, as the molecular GBMs or, the CDKN2As and whatnot.
Yes.
And so, they even if it's a non-enhancing glioma in an older person, it usually, at least here, ends up being a GBM. So, but I'll keep you posted as we acquire more patients, But anyway, listen, man.
Yeah, sorry.
Go ahead. No, go ahead.
Just if I may ask, what do you do with a young patient that you don't want to irradiate because the volume is so huge and maybe you don't want to operate on it?
Yeah, we've been pretty aggressive in general. So I would say I've got a few people, young patients, let's say dominant hemisphere subtotal resection. We would treat temozolomide and PCV, obviously for an oligo. We really reserve that for oligos. We would treat temozolomide and Stu protocol with concurrent radiation. Clinical trials for these tumors are rare. And so there's not a lot out there. And so we're working on a few, but it's a tricky disease without a doubt. Now, again, I think the tricky one, or maybe not that tricky, is a right frontal low grade where you get a gross total resection in a young person. And then I think it's that question of wait and see or treat. And I think, I don't think there's a wrong answer. And I actually appreciate your data. I think your data is convincing that, in the wait and see approach, you can actually have, maybe better progression-free survival, or at least as good. But I think we need more answers about what the concurrent therapy looks like compared to that also. So,
yeah.
And the future of this is coming, and it's incredible, right? As we get into a better understanding of neural networks and connectomics and whatnot, maybe network sparing radiation, right? We already do hippocampal sparing radiation, but maybe down the road we can start sparing some of the key networks. And maybe radiation, down the road won't be as morbid, in these patients who survive a really long time. So, but anyway, man, listen, thanks so much. I want to thank everyone for tuning in. We look forward to your next paper, hopefully in the JNO, and we'll have you back anytime. Thanks for staying up for us.
Thank you very much. Have a great evening.
All right, take care, everyone. See you next week. Bye-bye.
Bye.
All right, man. Take care. Thank you.
Thank you so much. It was great. Bye.
Bye.